Next case here is a 72-year-old never smoking woman who undergoes primary surgery for a node-negative 4.1 centimeter left lower lobe, moderately differentiated adenocarcinoma. So surgery first, 4.1 centimeters. Testing shows an activating EGFR mutation, but this patient is reluctant to pursue chemotherapy, far more amenable to targeted therapy. And so question, do you press her to receive postoperative chemotherapy, osimertinib, neither, both? Your approach is here. Anna, I think this is a very real world situation. And so what's your approach there?
Definitely very real world. I think this is something that we all encounter. I would show them the data. I mean, my recommendation would be to do chemotherapy followed by osimertinib. Again, we're trying to think of what has shown benefit of overall survival, which chemotherapy would. Osimertinib still, I think it's to be shown, but we are excited about the potential. And then going through, the supplement figures and Kaplan-Meier's that we saw from the ADAURA study, in which patients who received chemotherapy had, better responses overall, and trying to speak with the patient about what the options of the outcomes here are, and our data shows. I think in that study, of course, I believe it was around 40% of the patients did not get chemo, which is a limitation. But in those subset analysis, they were able to compare, and those who got chemo had better outcomes in terms of time to recurrence, which is something that I would explain to the patient in particularly, and try to pursue that route.
Happens quite a bit. I think that, chemotherapy is not something that most patients are excited about. Justin, is your approach any different here?
No, I do think, one of the challenges when we're talking about all of these different studies is the changes in staging classifications, right? Where we talk about stage 1B, and just remembering that, many of the studies we're discussing here in Power 10 and DORA, they were conducted under the 7th edition. We're now in the 8th edition, and there was that critical change, right? In 1B to 2 in the different staging systems. So yeah, and we've encountered this in our tumor board, where people are saying one thing, they keep talking about 1B, and then wait. Is what you're talking about the same I'm talking about? So we have instituted some guidelines in our tumor board around PD-L1 expression, and then around like T stage and which edition we're using, just to keep everyone on the same page. So I think in this patient, who this would have been in the 7th edition, a 1B, in the 8th edition, a stage 2. This is someone where I would recommend adjuvant chemotherapy. And, from my perspective, I think until we get cure rates higher, we shouldn't necessarily be de-escalating therapy. And chemotherapy is the one agent here that has an overall survival benefit that's been demonstrated. So I would offer both adjuvant chemotherapy as well as adjuvant osimertinib. If at the end of the day, though, the patient said, I'm concerned about adjuvant chemotherapy. When I look at the data, only a 5 to 10% absolute improvement in survival, like, thanks, but no thanks. I would still give adjuvant osimertinib. There was a follow-up publication in JTO showing that, either JTO or CCR, I think actually maybe CCR, showing that whether one received chemotherapy or didn't, the hazard ratios look pretty comparable, maybe off by a little bit. But I think in that context, I would certainly offer it with all the caveats of toxicity, relapse-free survival as a surrogate for overall survival, all of those things.
Yeah, our approach is very similar, and I think that we're just very upfront about the modest benefit. It is a real benefit in a lot of cases, but I think that we all have different values, and if for a modest benefit someone says that's just not something that sort of aligns with our values, then I agree. I don't think that any of us would insist on it, and I think that osimertinib still plays a role there. So important marks again in the future. Hopefully we'll be able to use some sort of biomarker, some sort of test of MRD to really see what people need and don't. But I think that we will acknowledge that adjuvant cisplatin-based chemotherapy can provide a survival benefit in resected lung cancer, but it is not, BEP in a germ cell tumor. And so it's a modest benefit, and it comes at the cost of some tox. And if someone's got a borderline creatinine clearance, maybe that tips the scales in a different direction. But yeah, this is definitely a very real situation. Osimertinib clearly playing a role there. Chemotherapy, it sounds like we're all recommending it, offering it, and then discussing with the patient.
Stephen, you raise a really good point, which is, assessments of MRD. And for all of our, where Thoracic's been ahead, right, in terms of molecular testing and targeted therapies, but the GI space now is much farther ahead than us in terms of incorporating MRD assessments into therapeutic decision-making. They already now have phase 3 data, right, that we recently saw at ASCO. So I think that's something where, can we use MRD assessments to either intensify, de-intensify therapy in the right context? I think that's where we need to be moving.